So basically, Prashant has to speak in the trabeculotomy with micromastitis. My topic is trabeculotomy with OLOGEN. So the ideal trabeculotomy is to regulate the aqueous flow. It should not be over-filtrate or under-filtration. The pressure should be in the control. To avoid late onset day thinning and its related complication, and to modulate the wound healing response to avoid the scar. And so do we have the alternative for improving the BLEB morphology? Yes, we have that. Without anti-metabolite, we can use the OLOGEN. OLOGEN, I'm not going to detail about the physical property of the OLOGEN. So what are the advantages of the OLOGEN is to induce the regenerative non-scarring wound healing to process without the use of anti-fibrotic agents. And it acts as an aqueous reservoir, creating a buffer to prevent plate or shallow AC, and easy to for surgical technique with a single or reusable suture, and also is enable formation of physiological functioning plate, and can be deployed readily without prior preparation. And surgery is made more time efficient by eliminating the need for the handling or application and disposable for MMC. The other advantages are it is not a teratogenic like mitomycin, and whenever you do surgery, the hydraulic pressure of the aqueous shock matrix provide resistance at the outlet of the scleral tunnel and to maintain the anterior chamber. So this is the BLEB morphology. You can see here the 614 stropper and then avascular, nice transparent, and then you can see the 12-month OLOGEN plan. So when we can do this, all type of primary glaucomas, and the specific indication are like thin sclera, either due to the high myopia or uveitis, or if the patient has any contraindication like cornea toxicity or cornea compromise, in case that we can use the OLOGEN. So in repeat trabeculotomy and all type of secondary glaucoma, we can use OLOGEN. So why should we not use mitomycin? Because it has many complications like overhanging BLEB, blebitis, cystic BLEB, and BLEB-related many complications. And the most related complication is endophthalmitis or kissing choroidals. So practical tips for success in the TRAB with OLOGEN is routine trabeculotomy till peripheral iridotomy should be done. I use a triangular scleral flap, and tips for the flap closure, which is the key step of success. The single reusable suture, a better option is 10-0 nylon or monofilament white clip at the apex of the triangular flap. Use the thin tying forceps to tighten the suture. So how much to tighten? That is most important part. The just approximate of the flap over the scleral plate with normal AC depth. You should not so deep, and use sometimes the visco to form the AC, and we should get a minimal leak is acceptable. If there is excess leak, additional suture may be placed. So what to look intraoperatively, or we have to put over the flap, just covering the apex of the flap. The size is either 6.2 or 10.2. How to close the conjunctiva? Meticulous closure of the conjunctiva with a proper approximation at the edge of using being sutured. And make sure no gaping exposure of OLOGEN at the side and also at the limbus. So, and we have to look the sterile peg. If it is, it should seal peg, and it should not like a paper like a thin and very thick conjunctiva. We can do panectomy at a small video, but time will not permit. So, thank you.